Welcome back to another episode of ACR On Air, the official podcast of the American College of Rheumatology. I'm your host, Dr. John Hausman. Private practice in rheumatology is under sustained pressure. Margins are tightening, prior authorizations are increasing, drug access is being restricted by payers and pharmacy benefit managers, and for many practices, the financial model depends on a narrow set of revenue streams that are becoming less predictable over time. At the same time, demand for rheumatology care is rising. There just aren't enough rheumatologists to treat everyone that needs it. Wait times sometimes stretch for months in many regions. So the question becomes, who's advocating for these independent rheumatology physicians? Who is working on the structural problems that individual practices can't solve on their own? Fortunately, the American College of Rheumatology has increasingly taken an active role in advocacy, healthcare reform, and workforce training, trying to make sure that independent rheumatology practices not only survive, but thrive. Today's guest, Dr. Nihad Solomon, sits at the intersection of these issues. He's the Chief Medical Officer of Arizona Arthritis and Rheumatology Associates, one of the largest independent rheumatology practices in the country. And he's also been directly involved in ACR leadership across committees, advocacy efforts, and initiatives focused specifically on private practice. This conversation is about what's actually happening beneath the surface, the pressures facing private practice, and what, concretely, the ACR is doing about them. Enjoy. Nihad, welcome to the show.
Hello, John. Thanks for having me.
I'm really excited to talk to you about private practice. So, private practice is not a topic that is often sort of seen or experienced by fellows in training, at least by most of them. And to me, it's a topic that feels pretty foreign. Sometimes the ACR seems like it's sort of made up for and by and for academic rheumatologists, but I know that that's not the case. And the ACR really puts a lot of effort in private practice and private practice rheumatologists. Most rheumatologists out there are in private practice. So I'm excited to talk to you about your experiences. Do you mind sort of introducing yourself and sort of how you came into private practice and your role now, which seems to be pretty awesome?
Sure. Thanks, John. So you're absolutely right. We don't get a whole lot of exposure in fellowship with regards to private practice. I trained in New York. I was part of the Stony Brook system and the NYU system for fellowship. Effectively, as I was finishing up my training, thinking about where I want to lay some roots, I was thinking of going out to the desert in Arizona. Like every fellow out there, most fellows want to do academic rheumatology. And so unfortunately at that time, talking about the early part of the 2000s, feels like a couple of decades ago, almost 3 now, huh? I was looking for opportunities in academic rheumatology, and there really wasn't any. That having been said, my wife and I really wanted to live in the desert, so we had to make inroads. So effectively, at that time, the internet was still a new invention. Google was just coming out, maybe it had been out for a couple of years. And I started doing Google searches. I think you might remember, and I'll date myself, Alta Vista searches, all sorts of interesting kinds of searches to try to understand what the market looked like. And the vast majority was about 4 or 5 small groups in the Phoenix metro area. And so I reached out via fax with my CV to all of the different practices that I found online. And I had some quick phone interviews, and I said, I'm coming out there to do some work. I was fortunate enough to meet with Dave Yoakum out of the University of Arizona down in Tucson, which is at least a 3-hour drive from Phoenix. who invited me to come out on the Native American reservations to see some B27 disease. And so I
Mm.
was very excited at that time. And I said, hey, I may as well kill two birds with one stone when I'm out there for the week. Let me see if I could reach out to these independent rheumatologists and have some formal interviews. And it's funny, I put out, I think, 7 applications. I got 6 opportunities, although none of them were advertising for jobs. Sat with them and I got 6 offers. And so it was exciting to be wanted, but I still wanted, I desperately craved the academic portion of it. So that having been said, I chose one of the jobs. I came out to Phoenix, and the first thing I did was found the local medical school and became an adjunct clinical assistant, eventually a professor over the last 3 decades, teaching the students, having them rotate with me, and then slowly but surely integrated clinical research into our practice. So I had that sort of
Mm.
element of academia. And then more recently, as our practice grew, and I failed to tell you guys, I'm the head of the CMO of the largest independent rheumatology practice in the nation now. But it started off as having, I believe, about 6 partners. And eventually now we are at 24, plus we've got a couple in the waiting in the wings. And we also have 60 advanced practice clinicians.
Wow.
I've worked my way up to the director of clinical research as well. And so I really do feel like our practice is, although it's private practice, has a lot of the moving parts of academia as well. And more recently, John, we collaborated with the Honor Health system to create the first, at least in Phoenix, the first integrated rheumatology fellowship between academia and private practice. And we have fellows rotate through a couple months out of their training every year. So that's been an exciting endeavor. We also have residents and sort of try to introduce them to rheumatology earlier in their career, from the medical student phase to the medical resident phase, and then ultimately graduate them under our supervision from as fellows.
That's incredible because you often, at least in my mind, when I think about private practice, you're there with the patient, and what you're lacking is the research and education. But what you're telling me is that in your private practice, you were able to incorporate both research and education as part of the trainings. You got the best of both worlds.
Yeah, when there's a will, there's a way. And we were all very like-minded in our practice and wanting to nurture that academic desire. And it's true, everybody who joins us is like, I thought we were missing out. And even before the fellowship, we incorporate, as I told you, about 60 advanced practice clinicians. So effectively, the APP functions like a fellow. And so we train them, and every team has 2 or 3 advanced practice providers working with the lead clinician. And so they're like fellows that never graduate. They stay with you forever until they move or some life circumstance happens. But that's been the other part that nurtures that desire to train and teach, but also leverage the workforce that we have since there's such a dire shortage.
Great. You've set it up perfectly. So, at least in academia, I can tell you that there's a lot of pressures for us. My hospital is merging with other hospitals to make things bigger. They really want us to lower costs and see more patients. I wonder from your perspective as, the CMO of, as you mentioned, the largest private practice the rheumatology practice in the nation, what are the biggest challenges that you're facing as a private practice rheumatologist?
So initially, I would say if we rewound the clock about 10 years ago, we really felt the dire straits of bottlenecking in terms of access to get our patients in. And that's where we've refined the utilization of advanced practice providers such that we can leverage that and allow patients to get in sooner. Now, most rheumatologists will say they have a 3 to 6 month wait period to get a new patient in. We have a 2 to 3 week wait period.
Wow,
So we've
amazing.
effectively met the demand. Lots of fits and starts until we got it right, but eventually we got it right. And we have an onboarding process. We have an education process. I think people think that onboarding an APP is easy, but it's really easier said than done unless you have a playbook. So we devised this strategic playbook that allowed for education before they start education during the first 2 weeks of onboarding with respect to the EHR, and then eventually with respect to the discipline itself. And slowly but surely, there are certain goals they have to meet over the course of several weeks. So in doing that was the first hurdle. The other hurdle was access for patients to biologics. As we know, and I'm sure you feel it in the hospital system as well, there's constant pressure. Use this drug, don't use this drug, bottlenecks in this. And I think the pressure release that we have is the clinical trials research. So it's another avenue by which we can sort of bypass, as long as the patient is willing to participate in clinical trials research, bypass that sort of headache, if you will. But I think those were the two biggest hurdles. And then the reason we are so large is because the smaller practices were faced with lots of headwinds, and more recently margin compression. As we know, the buy and bill model is the crux of what keeps the doors open. I mean, unfortunately, it's hard to keep the doors open if you're just seeing patients. You have to have some sort of an ancillary in the background to keep revenue flowing.
And you're talking about infusions.
Correct. The buy and bill infusion model. Correct.
Yep.
And so that's, again, getting into private practice, not having the first clue about any of this. I was fortunate enough to stand on the shoulders of the giants that came before me that actually set the whole thing up back in the early part of 2000, 2001. And from their learnings, we continue to grow and build on that. But even of late, maybe in the last 3 years, the margin erosion, so that little bit of profitability that kept the lights on, has continually been threatened. And so the reason we grew was a lot of the community-based rheumatologists in the area, I told you we were very fragmented, came together and said, look, if we don't get together, we don't have the bargaining power to be able to negotiate, whether it be with the distributors or whether it be with manufacturers in various aspects for rebates, etc. And so that's how and why we've become so large. And I think this is the same reason why you see in hospital-based medicine the consolidation of systems. It's about economies of scale. It's about reducing costs. It's about increasing access for patients. But the key that's missing, unfortunately, is continuing the quality of care. And we have to be very careful. And as a CMO, that's my priority. I understand the economics behind medicine, but I'm first and foremost a physician and clinician who cares about the well-being of the patient and wanting to provide them with the excellent care that they deserve. So I think we should never lose sight of that, regardless of whether you're an independent practice or hospital medicine.
And Nihad, over the past few years, you've worn a lot of hats for the ACR. I wonder if you could talk a little bit about how the ACR helps to support what you and other private practice rheumatologists do over the last few years.
Yeah, so in 2019, I was fortunate enough to be invited to Cork, which is the Committee on
Rheumatology
Care. Exactly. I found a lot of my private practice rheumatologists side by side with me. I guess that's a great gateway into understanding what ACR does for independent rheumatology. So I spent 3 years, and during those 3 years, I rubbed elbows with the Government Affairs Committee, GAC, as we call it, did a lot of advocacy work, and it's amazing. A lot of the advocacy work really revolves around championing elements that affect both the private practice world and hospital medicine, because there's a lot of similarities. And I'll sort of reflect back as a fellow, the ACR was this amazing scientific program that happens on an annual basis. And then you have a few smaller programs throughout the year. And that's kind of where I left it in my mind when I went into independent rheumatology, and I probably didn't revisit. Remember, I told you the early part of the 2000s is when I got into private practice, and it wasn't really until about 2018, 2019 where I re-engaged. And to my surprise, there were so many initiatives that the ACR was taking on for private practice rheumatology. So Cork being one, Government Affairs Committee being another one. And then during the course of those 3 years, Cork sort of fostered and gave birth to the CPC, which now is the Independent Rheumatology Subcommittee. So an entire subcommittee that is dedicated strictly for the well-being, best practices, and resources for independent rheumatologists. There's a lot going on for independent rheumatology. And I'll tell you, when I got a call and sort of inviting me to apply for work on the board itself, I said, wait, that's a thing? Like, we're allowed to be on the board? And I found it to be sort of somewhat comical. So in my mind, again, I thought the board was meant to represent its constituents. And again, the preconceived notion that I had was, well, this was mainly more of a scientific,
Mhm.
academic type of community, but it's really not. In fact, there's a balance between on the board. Certainly, I think now there's probably out of 13 board members, at least half, if not two-thirds, are community rheumatologists, not academics. And so
Mhm.
we do get a voice. We get a big voice. And I think there's been a lot of support, specifically, at least while under the time that I've been engaged in the ACR in the last 6, 7 years, of a real push to reveal and support independent rheumatologists. The things that I remember clearly was working on this white paper with regards to the detriments of white bagging, which then quickly morphed into the benefits of the buy and bill model, which is the outpatient infusion. But it really wasn't meant strictly for independent private practice rheumatologists. It was meant for anyone and everyone that touches this service line. Other areas include sort of the value of rheumatologists. And I think we've been undervalued, specifically in the hospital systems, because you get a flat salary and a small bonus based on work RVUs. And as we said earlier, seeing patients doesn't pay the bills. But the reality is, everything that stems from rheumatology, whether it's referrals to the infusion suite, whether it's referrals to research or referrals to orthopedic surgery, there's so many downstream revenue touch points in a hospital system that we as rheumatologists don't get credit for. Certainly, you don't get any bonus from it, but it should be recognized, at least with respect to the value that rheumatologists bring to a hospital system.
Couldn't agree with you more. I think that's a big point when we're thinking about, right, like rheumatology salaries from a hospital is recognizing all of those ancillary services, in addition to the infusions, the imaging studies, the procedures that we refer patients to. Talk a little bit about some of the wins that the ACR has had on behalf of community rheumatologists and rheumatologists in general.
So, I mean, it's certainly starting with creating the independent practice subcommittee, which is a specialized volunteer group within the ACR that focuses extensively on rheumatology needs in the independent and small community practice world. I mentioned before, they've created guideline and criteria apps. So these are some of the resources, some of the toolkits that are available to us. They have advocacy funds as well. They have their own attorney that works in DC to help with lobbying. And with that, some of the wins include a 2-year extension of telehealth flexibilities under Medicare. Some of the wins that ACR's really helped with is transparency and reporting for pharmacy benefit managers under the Medicare Part D. This is a new hot button topic for independent rheumatologists, with having either an MID, which is a medically integrated dispensing vehicle within their practice, or also known as a pharmacy within your practice, so that the self-administered medications can be given. So decoupling of the PBM compensation from drug prices, all of this is these are huge wins, because there's a lot of there's a veil that is covering all of the backdoor dealings of this vertically integrated society of pharmacies, with PBMs, with insurance companies. We know the issues again with United and Optum and that vertical integration itself. And it's very hard for independent rheumatologists to break through, even on the pharmacy side, outside of the Medicare system, because there's almost, I hate to say it, but almost like a mafia with
Mhm.
the integration of PBMs in this. And so having drug pricing reforms and the prohibition of the spread of pricing in Medicaid all wins. There's also research investments that ACR has supported, whether it be through the NIH or the Centers for Disease Control. So, I mean, all of these are some of the wins more recently that we've seen, but even in the past, just the work that came out of Cork, some of the white papers were really invaluable. I mean, we reference the white paper on white bagging and its detriments all the time, especially when we get pushback from third-party payers that say we have to white bag their product because the cold chain of command gets broken. And especially here in Arizona, where the temperature, you get to 120 degrees in the summer, I mean, it's very reasonable to believe that if a shipment happens over the weekend, it sits outside the office, the drugs get denatured.
Talk a little bit about prior authorizations. It brings a little bit of PTSD to me, and I'm sure to a lot of rheumatologists that are listening to this. There's a lot of discussions about burnout. Maybe this could be a big source of burnout. Talk a little bit about what the ACR is doing in regards to prior authorizations and making life easier for physicians.
John, I grew up in Staten Island, New York, and we were surrounded by a lot of Italians back in the day. Prior authorizations gives me what we call agita. Just gives me a heartburn. For years, it has been the bane of our existence. And I will tell you, there have been multiple attempts from independent rheumatologists to try to work with third-party payers and find pathways by which they can eliminate prior auths if they adhere to a pathway. And we've had a couple of successes. And it looks like in the last couple of years, the ACR is trying to leverage similar concepts, but on a national scale. That's one of the things that I'm aware of that they are actively working on in a way where they can, one, we can, as a nationalized group of physicians, work together to try to get rid of prior authorizations, but with using best practices. So that's one example. I know that there's a lot of lobbying efforts as well from an advocacy perspective, explaining that, prior auths are not good for patients. They delay patient care. Prior auths are really just a stumbling block meant to delay the utilization of medications by 1 quarter or 2 quarters to fiscally incentivize the third-party payers. And it's just an unacceptable practice. I cannot see any good that comes out of prior authorizations. And even more concerning, in 2026, there was a push early this year to try to have a few states, Arizona being one of them, to employ through Medicare, which, doesn't require prior authorization. We already see it with the Medicare Advantage plans, or the disadvantage plans, as I like to call them. But, to do this in Medicare, which probably comprises anywhere from 40 to 60% of most people's book of business in independent rheumatology, is maddening. And I know that there's been some pushback against that as well.
Yeah. What ACR resources are available when talking with payers or trying to deal with prior authorization denials?
So there is a treasure trove of ACR resources. Unfortunately, one of the things that we've tried to do is bring them up front and center. But out of all of the things, just in the 3 years that I served on the board, that we had stamped approval and pushed forward are countless, just in the 3 years. So I can't imagine in the last 2 decades what kind of treasure trove we actually have. But there are, number one, using the guidelines and the criteria app helps independent rheumatologists while in their day-to-day quickly glean. So you can reference ACR guidelines. That's number one. So when you get pushback and they're asking you to use 3 or 4 TNFs before you move on to another MOA, you can clearly demonstrate that's not 2026 medicine. It's not even 2010 medicine. So we need to kind of get over that. When there's pushback, as I mentioned before, with white bagging and an insistence, there's various papers and resources that you can reference from Cork that help as well in the efforts. And we've done all of those things. And believe it or not, we actually have a team that pushes back. It's costly, but it's effective, and it minimizes that burnout that you're talking about. But it is an independent team that has access to all of these references and uses them to push back when we get denials.
What other ACR resources are available to help somebody in an independent practice sort of with their day-to-day operations? What other resources exist?
So there's advocacy as well. There are small team memberships. Like, so if you're having trouble, let's say you want to get everybody on board, you can get a small team membership of anywhere from 4 to 6 members or even up to 15 members at a discount. There's insurance advocacy. So there's the subcommittee, this insurance subcommittee that's through Cork that surveillances things like bad actors. I remember a few years ago, Blue Cross of Tennessee, I believe, was trying to mandate across the entire state white bagging. And so they got wind of this and they quickly turned around. So if you're dealing with something in your state, I'd encourage you to reach out to Cork or the insurance subcommittee or both. Bring this stuff front and center, and they will in real time advocate for you and work through this. So the ACR isn't just, oh, here's a bunch of references that you could find, but they're living, breathing advocates for you, both at the national level in DC as well as state by state. And they've coalesced and worked with now other organizations like CSRO and state advocacy groups within each state. ACR has made an effort to appear at RPPA, for example, the Rheumatology Private Practice Alliance meetings, as well as state meetings and CSRO. So there's been a real big push for full integration. Other things like clinical and operational tools include the RISE registry, the MIPS value pathways. I know we're struggling to try to stay up with the MIPS and the MACRA. And so we have resources and tools available to us that ACR has put together to help us navigate that and not get those punishment points away from us.
How does the ACR decide what issues to address? Like, if you're an independent rheumatologist, how do you sort of push for the issues that are affecting you day to day in your practice?
If you're aware of the channels, I think the ACR is nicely structured such that you can quickly find the vehicle by which they can help you. And I think the creation of the Independent Rheumatology Subcommittee is probably a good place to start. It's a good place to start to serve if you're interested in serving, but it's also a good place to voice your concerns. You can go right on the website and you can reach out and voice your concerns through them. They can certainly channel the concern and escalate it, whether it be to Cork or subcommittee on insurance. If you've got advocacy concerns, you can go directly to GAC. There's a phone number for the office in DC that ACR has. And so there shouldn't be a shortage of tools for independent rheumatologists to utilize. And it really starts at the level of the website where you can find the numbers, the emails, etc. And people get back to you very quickly.
Looking forward, sort of as the CMO of this large independent rheumatology organization, what are some of the wins that you're seeing in terms of caring for patients with rheumatic diseases? What changes and challenges do you see over the next few years that, may need to be overcome, that hopefully the ACR will focus on over the next couple of years?
Back in, I guess it was 2015, Dr. Badafarano wrote a paper on the workforce shortage. And I know that he spearheaded the Committee on Workforce Solutions. I had the pleasure of serving with him for a couple of years on that committee as well. There were originally 5 pillars that shrunk down to 3 pillars of strategy. One being expanding the rheumatology fellowships and funding for expansion of existing fellowships, as well as resources to help create new fellowships. I told you we were recipients of that good fortune recently here in Phoenix. The second is recognizing where those fellowships need to be expanded and cultivated. So in more rural areas, in areas where there's a dearth. So there was a huge workforce study that was done. And the intention is to expand programs or create programs, stand them up in areas where there is the dire need so that where you train is where you work eventually. So that's number one. Number two, there's a huge push for educational resources to train advanced practice clinicians or providers, APPs, whether it be for independent study or whether it be actual virtual links that they can watch in real time. So ACR is taking the most brilliant minds in academia and putting them to work, creating video links so that they can train. There are also other strategies. Again, the workforce shortage, I think, is the number one and the biggest problem that we have. And so ACR has really grabbed it head on and thought about the various ways to achieve successes in the short term with advanced practice provider training, and in the longer term with the expansion of rheumatology fellowships. But above and beyond that, there's even a third arm that's looking at internists and training internists with more depth in rural communities. For example, Wyoming. I mean, good luck trying to get rheumatologists to coalesce in Wyoming. But if
I
you
hear it's
can have,
beautiful though.
it's gorgeous. It's gorgeous. But, again, Wyoming probably needs 2 or 3 or 4 rheumatologists, and maybe they have 1 for the entire state. And so
Wow.
what they're doing is trying to stand up virtual connections for the internists with an interest in rheumatology, train them so that they can sort of help 50% of the way and alleviate some of the bottlenecks in those rural communities. From a pediatric rheumatology standpoint, because we haven't talked about that arm, there's a dire shortage of pediatric rheumatologists, not because the programs don't exist, but they can't seem to fill them. And so there has been a push and various strategies to try to incentivize pediatric residents to gain interest in rheumatology, whether that is by perhaps shortening the span of the fellowship or incentivizing post-training debt forgiveness for medical school loans. And so there's a variety of different other things that are being looked at. Additionally, there are grants for APP. So for small practices that can't afford an APP, they can apply for a grant and actually get probably enough money to cover 75% of the cost of an APP in their first year. And so I know we contribute to that grant in as much as we believe in this mission, but there's lots of money out. I haven't heard of a small practice who's applied and not gotten the grant money for the onboarding of an APP.
Yeah, we just did an episode about APPs and how to integrate them into your practice. And I totally agree. Our guest talked about how he was part of one of those grants and it allowed him to get training before, starting to see patients on his own. That's a huge resource. There's been a lot of discussions about artificial intelligence and how that may help improve care. In your practice, are you using AI now? And how do you envision that changing over time? And is it going to impact the care that you provide your patients?
Funny you should ask. Yes, we're using quite a bit of digital tools and digital integration in our practice. We're trying to minimize the need for excessive human error and human touch points. Now, that's not to say we want AI to replace everybody, but on the contrary, we want to leverage AI for efficiencies within our practice. And we have. For example, in the research realm, trying to identify subjects, as we call them, or patients for clinical trials is burdensome, right? So you either have to wait till they get into the office, you're looking at them, you're thinking about them, or you can input into a funnel the inclusion exclusion criteria and have AI spit out a panel of 20 or 30 patients that could benefit from a trial. And then you can have the human CRC look through those 20 files and see who's appropriate, then bring maybe 10 of them to the forefront of the clinician and have us say 5 of them might work. Let's call them and bring them in. So that's one example of the use of AI. Another example is using them for workflow purposes. So we've looked at our processes and found, whether it be in revenue cycle or operations flow, for prior authorizations, kind of bringing it back full circle. Can we use AI, whether it's to generate letters of medical necessity or whether it's to automate and operationalize various strategic points that we've had that have become bottlenecks because of human error? All of these things we've been employing, and now to the point where we've refined them well enough that we're about to scale and become a national MSO for small practices to help small practices do what we do. But we couldn't do that without A, the learnings that we've had over the last 30 years, B, the employment of digital tools, and then C, a management C-suite team that really knows and understands the business and really pushes it forward.
I've been very excited with, all the AI advances so far, and I really can't imagine how it's going to change our practice going forward. But hopefully, as you said, like reducing error and improving care. And I feel like in terms of like writing PA letters, it's going to be like our AIs fighting like the insurance company's AI to to reject. It's going to be like AI versus AI.
Well, actually, insurance company AIs are being shut down. My understanding is this is one of the other advocacy pushes out there to fight back against insurance companies' utilization of AI for denials of
Interesting.
prior auths, but
That's
not
good.
the reciprocal, which is good for us, right? So we
Good
could
for
use
us.
it, but they can't. That's one of the pushes that I recall also recently happening.
Got it. Great. And then just one last question. If you could give advice to a busy independent rheumatologist who feels like overwhelmed and doesn't even know where to turn to, how can they sort of engage with the ACR and leverage some of those resources that you mentioned? Like, where would they start?
I would say, number one, I hope they start by listening to this podcast because there's rich information being delivered, right? Number one. Number two, visit the ACR website. It has been revamped. They're continuing to revamp it to make it user friendly, but also bring some of those tools and links front and center. If you have the bandwidth and the time, engage with the independent rheumatology subcommittee. I know that there's such great interest that there's a waiting list of folks for the next few years who want to volunteer. But even if you don't have the time to volunteer, at least make yourself aware of the tools that exist, not just on the website, but even for apps that you can help your APPs, whether it be on guidelines, etc. Make yourself aware of all of the benefits that being an ACR member grants you, the advocacy that is available to you, so that when the ACR sends you emails, don't ignore them. Take a look at them, not just at the recent wins, but also when they say, hey, we've got this advocacy push. We need your voice. Your voice matters, whether it be at the state level or at the federal level. Don't ignore those emails. I think those are ways you can be involved even if you don't have the time. As simple as just reading an email, visiting a website. But as much as engaging, I've had a lot of fun, collegiality, both working on Cork as well as the CPC, or now it's called the Independent Rheumatology Subcommittee, and some of these other committees as well for government affairs as well.
Amazing. Nihad, this has been a super conversation, super interesting to hear about what you've done in your career and how other independent rheumatologists can leverage some of the teachings, the learnings that you've had, and how they can leverage the ACR to, again, make sure that they survive in this very challenging climate and provide the best care for their patients.
And I'll say not just survive, but thrive. We need them to thrive. Absolutely.
Amazing. This has been great, Nihad. Thank you so much for your time.
Thanks, John.
The challenges facing private practice, including prior authorization, reimbursement pressures, drug access, and workforce shortages, are not problems that individual physicians can solve alone. They are structural. They sit at the level of policy, payers, and system design. And that's where the American College of Rheumatology is increasingly operating. But these efforts only matter if physicians engage with them. The infrastructure exists, but it isn't automatic. It depends on your participation, which may include reading those emails, contributing to advocacy, and joining committees whenever possible. Thank you all for listening, downloading, subscribing to our show, and for rating us with 5 stars, or however many stars you think we deserve. You can find our show notes for this and all other episodes at acronair.org, on Apple Podcast, Spotify, and on your favorite podcast app. Until next time, get involved with advocacy with the ACR. And of course, stay healthy.
This podcast was edited by Resonate Recordings.